and all the clinical staff working in the actual clinical processes that are getting changed. And one observation to make as I'm going over time and getting the stink eye is that these processes may not operate in parallel. The education development may occur, proceed to the education operation, which then initiates the clinical development, right? You've got to figure out what's the right sequence for each of those. The last comment would just be to comment on risks, which we didn't talk about a lot yesterday, but the risks of any performance improvement issue itself are just whether you're shifting costs from one place to another. Are you really saving money? The substitution risk that what the thing you're choosing to do is distracting people from doing other things that are important and add value. The potential liability if a new process has undesirable outcomes. And some important cultural issues, which is that any unsuccessful educational engagement or clinical engagement that fails generates cynicism, which is a sea anchor for future improvement. And the risk that some interventions you develop may be at odds with other performance improvement goals. The example Lucy gave when we were talking about this was to improve certain ICU infections. They may have a bundle that leads to automatic antibiotic use, which may contradict an antibiotic stewardship goal of a different change package. So that's what we got. So thank you very much, and thanks to the group for helping us
Thank you,
think about all
Stuart.
that.
Sylvia.
Hello. In our group, we were exploring the business case for the professional associations, and I had the joy to work with Mike Rose and Elena Carahana. They're not here today with me, but they left a lot of their input in what we did yesterday. We presented two cases to frame the discussion. One of them was in a pharmacy-based immunization delivery certificate that is put forward or spearheaded by the American Pharmacy Association. And the idea is to train the pharmacists to be immunizers. And I'm going to go a little bit more in the next slide about how we build the business case for that one. The other example was in the international context and is also spearheaded by the American Pharmacists Association, and the program is called SMART, and it is a case to train pharmacies in Turkey and community pharmacies in Turkey. And in this case, they were working on a program to help delivery of asthma-related education and the use of asthma products. In the case of the Turkey one, it was presented like a case study that needed to be worked the financial or the economic part of it. Okay. In terms of the summarizing for a business case, the case of the pharmacist, the training for pharmacists to immunize, I'm following the template that we were exposed in the morning yesterday. The APHA, I'm going to read through it for time issues. The APHA certificate trains pharmacists to be immunizers so that they can contribute to increased rates of immunization, the education, and the access. These trained pharmacists are a necessary component to deliver flu vaccines to adults in community pharmacies as compared to elsewhere. Then the question was, is there a cost benefit associated with the training and availability of immunization services in the pharmacy? In the period from 2007 to 2014, there's evidence that the cost of the training to pharmacy was almost $50 million investment in training by APHA and its affiliates. The cost saving of immunizing in the pharmacy, and then here is as compared to somewhere else in the pharmacy, as compared to doing the immunization elsewhere, was 2.4 billion. Hence, the net benefit is 1.9 billion. The conclusion of the case is that the expansion of the scope of practice, in this case of the pharmacist, has had a substantial impact in the cost of immunization, and whatever all this means for other public health and access issues. There were other things that we discussed here that even though there is a cost-benefit evidence, there is not necessarily an increase in rates of immunization globally. So it's a shift of place rather than a change in rates of immunization. And this is flu vaccines for adults. And there were a lot of questions. Some of the part of the session was a lot of questions about how this case, the assumptions that went into those numbers, that not necessarily, we necessarily agree with all the assumptions behind the analysis itself. Okay. Then we went to a part of like, let's open this up to look about, we didn't do the stakeholders analysis with the case. We at this point open to all the other associations and the role of the association in a general term. Who would be the stakeholders for professionals associations and CPD? We went to a big list, and Elena was very good in facilitating this part. And we talked about many stakeholders, and then we even had a voting system and got the first 6 main stakeholders. And interesting to me, the first stakeholders that the group found was the professional associations themselves. So they see themselves as stakeholders, their associations, and because it's the main and the other related ones. Not the professional associations are also affiliated, and we saw this morning. There's credentialing associations, there are licensing associations, plus there are the specialist association associated to the main one. So the stakeholders themselves is that network of associations. And for me, that was very interesting to see that dynamic in the conversation yesterday. We also thought of the health professionals and providers of education who provide CPD, employers of the health professional, the patients themselves, and federal and state lawmakers and legislative body, because this was an interesting one too, because even if we talk about big CPD activities and high value CPD, if we are giving skills that are not in the scope of practice by legislation, then what's the impact of it? So we had a good discussion about the stakeholders. We then went to an analysis of taking the 2 main stakeholders and doing some the cost, the operating cost, and the development and operating cost that stakeholder will have to incur, and the benefits for that stakeholders. Being the professional association themselves the stakeholder, we went into a discussion on what would it take for a professional association to develop, and there's some of the cost, like the need assessment, that I thought that was very interesting, that the cost doesn't start with the actual course, but the need assessment needed to have a high value CPD. It's based on a good need assessment, and that has a cost. That was interesting that came up. In terms of the benefits, there are all the increased membership, the better recruitment, advancing the professions. These are benefits very much into the mission of the association. In terms of the health professionals, we went into the cost that the health professional had to incur to get the CPD, and the typical ones like the tuition, the fee for credentialing, the opportunity cost, the loss of autonomy and frustration with compliance. All those were costs that, but however, they saw that the benefits would be best practices, job advancement, and you have the whole list there. We didn't go into monetizing these things. We didn't have the time. We went to the question, we knew that we had very little time to go into the risk, so we went directly to the question, why would a professional association want to invest in the entity in CPD? And I think that this was a very interesting discussion, because I think that there was agreement in the room that they have to do it. There's the mission of advancing the profession. If you don't maintain those that advancement based on standards, so the risk comes from not doing it. So I think the risk came up when we were talking, especially in that number 3 in the list. We need an organized, consistent, standardized ways to advance the profession. If not done, the survival of the profession is at stake. I think that one summarizes not only if we have to, is it of value to invest in CPD, but what would the risk be if we don't? There was also the idea of lifelong learning came up, and the fact that this investing in CPD also is not the lifelong learning of the professional, but the lifelong learning of the association itself to renovate and evolve. And the overarching theme of the whole section was that the association have a mission of helping health professional practice to their field scope of practice, assurance growth, development, credibility, and survival of the profession. I think that theme summarizes very well what happened in the session. And thank you.
Thank you, Sylvia. We have one more, last but not least. Paul and Darlene will present Philanthropic with higher ed.
Thank you. Paul and I were part of a very rich discussion yesterday of exploring a business case for philanthropic and higher education investment in high-value CPD. And it was clear from the beginning that there were several disconnects. And the first was about the words. Some felt in the group that the word business in developing a case of support might not be seen as negative, but not be appropriate for all audiences. And so there was discussion about wording and building a case of support. And the other disconnect was an understanding of how philanthropy thinks and how higher education thinks. And we sort of, are not on the same plane of discussion. And really, most of our time was spent on that. The business case was sort of the backdrop, and we'll discuss that a little bit. But it was really this understanding of philanthropy and higher education. And I'll just say that I am only speaking from the perspective of my organization, which is a small family fund. It's private. We have a living donor, and it's multi-generational. So it's very different from an organization where the founder passed away 50 or 100 years ago, and it's being run by a professional board. I mean, we have a professional advisory board, but the family earned their money, and when there's grant making, it comes out of their wallet. And so it's for everyone applying for funding, it's just, you really need to know that and do your homework about what kind of philanthropic organization you are speaking to and what their mission is and what their values are. So the other disconnect was that philanthropy might be seen as not having a business mentality and not seeing things from a business case point of view. But that's changing, specifically with family organizations, family foundations such as the Gates Foundation, Michael J. Fox, Zuckerberg, et cetera. So that mindset is really changing.
You'll notice how seamlessly we work back and forth on this. So Darlene, how does your organization decide if the grant is a go or no-go?
We require a business case from day one. And if Paul is approaching us for funding, that's it. Like, that is the first thing. I need to make an 8-point one-pager for my family and for my advisory board. Here's the business case. Do you want to talk to this potential grantee or not? Yes or no? So, Paul, what about higher education? How do you decide if it's a go or no-go?
The money needs to come from a source with values that match the values of our university and our CPD program. Commercial support, for example, in continuing medical education, has high visibility guidelines. But there are other questions that are more difficult where guidelines may not exist. So I can point to an example for our university, especially around accepting tobacco money. The funding also must be sufficient to enable us to succeed in completing the CPD project at hand. We want to be able to dig deep into the outcomes model of your choice to see whether we're doing good. And then ideally, the funding source may become a stronger long-term partner, helping us to improve relationships with patients, with the health system, and the communities.
You're mentioning sort of a match between the goals of the organization and the funder. And from just a funding point of view, the goals don't have to be the same, but they can't be in conflict. I think, Lucy, you mentioned that yesterday when you were talking about partnerships. And so both the funding organization and the recipient need to have goals that are not in conflict, focused on the beneficiary first and foremost, but they can be different. So we're going to quickly go through our case. So we're funding a low vision and blindness initiative, and the goal is to eliminate children's blindness. It's a funding partnership, $2.5 million from the Jonas Family Fund and $2.5 million in a match from a university academic medical center. There are 5 program objectives: doubling the number of children receiving care by 2021, increasing the number of clinicians, nurses, scientists pursuing careers in pediatric ophthalmology, vision science, and visual rehab, and that's through fellowships. That's the CPD part of this grant. We're going to be disseminating the research that comes out of the grant, outreach, and advocacy. And it's over 5 years, which was an interesting point that we were talking about yesterday, the importance of it having that much time.
So the question of how CPD units in higher education can benefit from working with a philanthropic organization, we can have several benefits. One, we can do meaningful work producing a high-value program with high-value outcomes that address the mission of the funding organization as well as the mission of our university. Another is that we can demonstrate rapid success, solving immediate problems more quickly using the healthcare practitioners that we have in the currently in the workforce, instead of waiting for the pipeline to bring us a set of skills to solve the problem longer term, but also conditioning and facilitating that pipeline. It enables us to build capacity for further carrying out similar work in CPD. It enables us to specify measurable objectives for determining progress and relative success. And it enables us to pay the bills. It also gives us an opportunity to build new relationships with partners, patients, health systems, and communities. So I will be returning often to the notion of building evidence, and these kinds of projects, a 5-year project, gives us an opportunity to track performance over an extended period of time, helping us to identify or explore causal linkages that often are not available to us using other designs.
Our time is up, but one word about sustainability, which was very important in our group, just from the point of view of this grant and from our foundation. Sustainability is one of the first questions on the business case at the very beginning. So the philanthropic investment is phase 1 of a project, then there's phase 2 and phase 3, but sustainability is part of the discussion from the very beginning. Thank you.
A final point here is one of the messages, that message probably was one of the most, if not the most visible, because it was mentioned by other philanthropic organizations too, was have your business case together when you come to the door. Have explored the mission of that organization and have your business case together.
Thank you. Well, it was very obvious to me listening to these 4 distinctly different business cases that were very individualized to the investing entities and the philosophies of them. So it's almost as if there was a different lens for each one of these presentations. So thank you very much. I know that we're out of time, but I have one last question to ask. I would like to have privilege to ask, if that's all right, from my co-chair. Was there anything missing from our discussion today, from these 4 business case examples and their identification of costs, risks, benefits, outcomes? Was there anything that anybody picked up on? Yes.
I think one could argue, which is a prelude to what I'm about to say, that what's missing is conflict, and that it all sounds wonderful, except that there are, in a sense, conflicts here. I won't go into the one with the with philanthropy. What I'd say is that Sylvia makes it sound, and I don't want to pick on you in this conflictual mood, but in fact, you make it sound like a reason for professional organizations to be in this is a little bit defensive. You know, if we don't do it, they'll do it to us. Whereas the boards and accreditors are in fact trying to move the profession forward, and often, in my sense, is faster than the profession wants to move forward. So to say that everybody's in this together, I think smooths over some of these conflicts, and that ultimately one has to get at those. And one of the beauties of interprofessional activity is one hopes that one learns to resolve conflict. It'll continue to exist. Put 2 people together long enough, it's got to be there. But anyone who's been married for a long time or whatever knows that at some point you have to be able to figure out how to resolve the conflicts. So I would hope, we don't have time to get into this today, but I would think that that's a worthwhile area.
I like to, because I think that's why the professional association identified that one of the stakeholders is themselves, because they found that stakeholders usually have that conflicting view. So the group saw that potential conflict. So I want to answer that. Maybe I said it too nicely, but it was there.
Yes, thank you for making that point. Yes, Patricia.
I think the thing that was missing for me, and I'd mentioned it yesterday, is WIFM. What's in it for me as the individual learner? And I think we continue to put stuff out, as we talked about yesterday, and how is it that the individual is really engaged, motivated, if I can say even enjoy the learning. You know, how is it that we have a bunch of systems here, but are we going to get somebody just playing along and checking in and checking out, but where's the engagement from the provider learner person?
Thank you. And what I just realized is we're really getting into the next step of reflections over the last day and a half. So I think this is the opportune time to segue into our next presentation. But first, I want us to thank all the speakers who reported out on their groups. Thank you very much.